Please welcome to the stage Darcie Johnston, Thomas Engels, Dr. Rick Lambert, and Dr. Travis Smith.
Good afternoon. I'm Darcie Johnston. I'm the Deputy Principal Director of the Office of Intergovernmental and External Affairs in the Office of the Secretary at the U.S. Department of Health and Human Services. And I served in the first Trump administration as the Intergovernmental Affairs Director and joined the 47 administration in February. And I'm happy to be here with my colleagues. One correction, Art Kleinfeld is not here. Dr. Rick Lambert is joining us from SAMHSA. So just that correction. And I'd like to pass it off to Administrator Engels for introduction.
Well, thank you, Darcie. And the beauty, this is my second go-around, too. I was also part of 45, and now I'm part of 47. And the great thing is, I also get a chance to work with Darcie again, that she and I worked together the last time. But my name is Tom Engels. I am the administrator of the Health Resources and Services Administration. And as I said, this is my second go-around, and it's a privilege for me to come back as a second time. Because the first time, I came in and had a lot of opportunities to realize I knew conceptually what HRSA does. We serve underserved areas, and we have a number of programs that we offer that help millions of lives across this country. But by the time I really got up to speed as what we were doing, COVID came through and everything changed. This time around, it's been great. I've been able to hit the ground running, know the staff, know what we need to do, and we're making a lot of great changes. It's great working with Secretary Kennedy. It's great working with this president. They really want to make changes in our healthcare system, and they are a driving force to get this done. Now I'm going to turn it over to Dr. Lambert.
Thank you so much. This is my first Health South Connect, so welcome everyone, and thank you, Darcie, by the way, and Tom. Good afternoon. On behalf of Dr. Art Kleinschmidt, who's the Principal Deputy Assistant Secretary for SAMHSA, and myself, it's really an honor to be here. Again, my name is Rick Lambert. I'm a physician and a senior advisor at SAMHSA. I also co-chair the Interagency Task Force, which makes up SAMHSA, the Veterans Administration, DOD, that works and focuses on suicide prevention, improving mental health and substance use disorder treatment services for service members, veterans, and their families. I've been practicing clinical medicine for over 40 years. Initially, I was in emergency medicine, much like Dr. Smith here, and did that for most of my career, and then did physical medicine acupuncture, and more recently I trained in psychedelic-assisted therapy, as well as research, and have a significant interest in that area. And part of what brought me to Washington, D.C. was my interest in really helping veterans with PTSD and anxiety and depression kind of have a new form of treatment that I think is safe and effective. And again, that's undergoing a lot of trials to date, so I'm really excited about that. We're so grateful, by the way, at SAMHSA for President Trump and Secretary Kennedy for supporting our mission to align with the Make America Healthy Again initiative. Behavioral health conditions contribute to chronic disease crisis, and we know that's the focus of the MAHA initiative. So in the behavioral health area, these are kind of staggering things from our recent NISDA study. 1 in 4 adults has a mental illness. 48 million people have a substance use disorder. That's about 1 in 6. And 21 million adults have both. So that's almost 1 in 10. So we're facing these increasing rates of mental health conditions with an illicit drug supply that is toxic, dangerous, and unpredictable more than ever. And every American does deserve the chance to live a healthy, fulfilling life. So we can't make progress without addressing these things. SAMHSA is committed to the principles outlined in MAHA. Our core mission is to meet and deliver these services, and give all Americans a chance at a healthy, fulfilling life. And I look forward to talking more about this. Thanks.
Great. Dr. Travis Smith.
Good afternoon, everyone. My name's Travis Smith. I'm an ER physician. Currently, I'm a senior advisor at HRSA, and have the pleasure of working with Tom Engels and Margaret, and as well as with Darcie and Rick. I served prior to this, practicing in the ER for about 15 years, and also in the medical education space. I taught 3rd and 4th year medical students and residents, training them to become future physicians and part of the workforce that HRSA helps kind of distribute out into some of the rural networks and FQHCs around the country. I've been at HRSA now since early May, and it's been an awesome opportunity just to really see how HRSA interacts, with all the states, everyone there, passion projects. The people that are doing the jobs there and all the various roles from the Ryan White program to the FQHCs and rural health centers. I mean, it's passion. I mean, the government dollars are being well spent at the people who are operating that. And, I think everyone is, lucky to have Tom back to doing this. I mean, it's a passion project for him. Tom's up all hours through the night working hard. He's got a mission, and, his mission is really for to help serve the secretary and the president on all of their projects to make America healthy again and community outreach. So it's been a pleasure. So,
Administrator Engels, how is HRSA strengthening access in the workforce to deliver on Make America Healthy Again?
Thanks for that question, Darcie. And as Dr. Smith just talked about, HRSA has a very unique program. We have the behavioral or the primary care programs that offer a number of services out to patients. The FQHCs, for example, as you just heard Travis talking about them. But our health workforce program trains a number of providers. And I know all of you are probably saying, how can we get more providers into the pipeline? We want to find ways to get more providers into the pipeline. But I'm very pleased to be able to point out 21,000 clinicians have been trained through HRSA-funded programs. And through the FQHCs, which primarily serve people in medically underserved areas. It could be rural, but I'm from Wisconsin. It could be rural Wisconsin. It could also be inner city Milwaukee that also struggle with finding providers to come in and help take care of residents and patients. 35 million patients in this country have been served by clinicians that have been trained by the Health Resources and Services Administration. We have the Nurse Health Service Corps program. We also have programs that train dentists. In 2023, half the dentists that were trained, or 2024, correction, half the dentists that were trained in this country were licensed and had gone through a HRSA-funded program. Now, we know there's shortcomings. We know that there's struggles finding and getting providers to come out in the areas. Everybody wants to. We were at a health center here just recently, and we were talking to one of the dentists, the individual that's in charge of the dental program there. And he said, I'd love to be able to get as many residents as I could, and I'd love to be able to get a number of dentists that would say they want to work at a federally qualified health center. But you know what they really want? A new boat. They want a new house. And so they're not going to get that by working on an FQHC. But with the longer that they're at those programs, they realize the true quality of the care that is coming about and actually get to see the impact that it's having on patients. We want to capitalize on that. This secretary wants to capitalize on that. The president wants to capitalize on that. We need to find ways to work with providers. Recently, I was at a health center in Dubuque, Iowa. And the president of Dubuque University received a $60 million endowment from a family in the area that wants to provide and start a medical school at the University of Dubuque. They want it to be directed towards people working and coming from rural areas. We have opportunities. We need to really talk about the opportunities. We need to hear with people like you how we can work together to better utilize the dollars that we have to get more workforce training out there to make sure that the residency programs that we're offering are actually meeting the needs of the people and actually being trained in the way that's actually taking care of the patients.
Thank you. Dr. Lambert, how is SAMHSA embedding behavioral health into Make America Healthy Again preventative framework?
Thanks, Darcie. So I was thinking about that word embedded, and for SAMHSA, prevention is embedded. One of our centers is called the Center for Substance Abuse Prevention, and so it's kind of in our DNA. We're all about heading things off before they actually happen, and that's especially true now with the youth. And you notice that the Secretary is really focusing on youth because trying to fix things later on is much more difficult, as we know. So if we can get to the root causes right away. Substance abuse in childhood and adolescence is linked to higher risk of chronic disease, addiction, and mental health conditions. So, and again, from the survey from NISDA, these again are kind of staggering numbers. 1 in 5 youths has moderate to severe generalized anxiety disorder, 1 in 7 major depressive disorder. And we know that effective prevention works, it saves lives, and also a nice side effect is it saves money. So some examples of the Secretary going out and talking about excessive screen time and social media. So a lot of schools are starting to react to that and really push forward. That was something that was never really addressed in such an effective way before. SAMHSA also has Project Aware, which is about developing sustainable infrastructure in schools for mental health care. And lastly, the 988 Suicide and Crisis Lifeline. That's something that's pretty amazing. 17 million contacts so far to that line, so it's really preventing suicide. The President started that in his first administration. That's really been valuable. So we're quite embedded in the prevention.
Thank you. Dr. Smith, there's an overwhelming evidence that nutrition is one of the most powerful tools for disease prevention. Yet the vast majority of physicians graduate with little or no training in nutrition counseling. Can you speak on why it is so important that we demand immediate, measurable reforms to embed nutrition education across every stage of medical training, to hold institutions accountable for progress, and equip future physicians with the tools to prevent disease?
You know, I think this question, was posed, and it was one of the action items that the Secretary really wanted to take head on. And having the privilege to kind of work on this project, I think everyone can agree that nutrition and lifestyle medicine is kind of the focal point for disease prevention. I'm going to say 7 of the 10 most deadly diseases are nutrition-related diseases or causes. And we can do that through counseling and teaching and embedding this throughout the medical education continuum. So what we started is working with 9 major medical associations and accreditors, the LCME, COCA, MBME, the testing bodies for all the medical schools, ACCME, who does continuing education, ACGME, that oversees the residency programs. We got all of them together, and everyone has agreed on, since probably 1985, that nutrition is undertaught, it's undertested throughout that process. It's just no one has really taken the opportunity to hold each other accountable. I think what ends up happening is, you get the medical schools that really want to teach this, and there's some phenomenal medical schools out there that teach over 100 hours of nutrition and lifestyle medicine, and they embed it through all their competencies, and it gets tested. But that isn't enforced through the assessments and accreditation standards for medical schools, and a lot of them will just teach to board exams. And we know if the students aren't taught, if they're not tested on that stuff, they're going to pay attention to the things that are taught. So what ends up happening is medical schools will check the box, hey, we taught nutrition, and that nutrition fact is some obscure fact on, a biochemical pathway for scurvy or beriberi. But that's not really, what physicians need to deliver that care. I think patients want engagement. They want to be able to talk to their doctor about diet, food, exercise, and natural things that they can do to prevent them from getting into that chronic space. And what Administrator Engels always talks about is the longer we can keep people in that preventative space, that's where we want to keep them. It's a cost-effective strategy that we can, see how long we can prevent them from going into that. 7 of 10 Americans now have one chronic disease. 4 in 10 have 2 or more. So, we want to teach, urologists, OBGYN, pediatricians. They can have their directed discussions on nutrition and diet specific to that specialty. So that's why we were talking with ACGME on their standards and the ABMS. So we want all physicians to be able to talk about it and have the proper resources to do it. And on top of that as well, physicians, they want to spend more time doing it. And so, they don't want to be doing this stuff for free. So, working on the back end to having, working with CMS and Dr. Oz about getting some of these things that are reimbursable for their time. And physicians will spend more time doing that with their patients, if it's something that is, that'll keep their lights on. So we want to do this from, the undergrad medical education all the way through ACCME and continuing education.
Dr. Smith, that was very insightful. A follow-up for you, as you spoke on the importance of embedding nutrition education requirements across multiple areas, how do you think this will move us towards reversing the chronic disease epidemic as part of the MAHA agenda, and how folks in this room can play an important role in this transformation?
So the recent report came out. I think there was about over 120 initiatives in that MAHA report, specifically tackling, childhood chronic diseases and prevention. And I think everyone in this room, either works at a company, works at a hospital that deals with healthcare. I mean, I think this is where we can all strategize together and good, productive, preventative strategies for how can we all work together to make sure that we can keep people in that preventative care cycle. Whether it's more touches, more engagements, patients, I think the physician-patient experience for talking about nutrition, for talking about all those things, nobody really does it. Some people do it well. We want to create a proper, proper map and strategy that we can deploy and everybody can use it. And I think having everyone here being able to say, hey, I think this is a good strategy, everyone can work together, specifically like circling back to the FQHCs, you go into an FQHC, you see a primary care physician, you can see a dentist, an optometrist. I mean, it's time well spent talking about all of these things. They have food kitchens, teaching patients how to cook. The more time spent cooking a meal, the less chronic disease they have. I mean, this has been shown numerous times. So, these are all things I feel like everybody can agree on. This isn't a political item. This is something that will transform us from, one of the sickest countries in the world to the healthiest. I mean, I think right now our average life expectancy is about 78 years. On average, countries like us, 82. I mean, so we're well behind. But the good news is there's a roadmap and there's an ability for us to all do that. So hopefully we can stop pontificating about it and actually take action. And so that's what we're planning on doing right now.
Thank you, Dr. Smith. Administrator Engels, last week, HHS released data highlighting the long-term benefits to children and families participating in federally funded, evidence-based home visiting services through the Maternal, Infant, and Early Childhood Home Visiting, I'm not going to use the acronym, we've had enough of those, program. What is on the horizon for the program and how it advances the MAHA agenda?
It really advances the MAHA agenda. I'm really proud of this program. And I'm going to give you a few examples. This Maternal, Infant, and Early Childhood Home Visiting Program, MCV, trains not only their staff, but they have an opportunity when parents have gone through this program. And they've actually now come back and they are now teaching other parents how to be parents. That's the key to this program. They teach young people how to be parents. I want to give you an example. Recently, I was out in Denver, and I got to talk to some of the parents that were there. They had an example of a young mother, and I say young, she was 14. She opened up, in front of the McVie staff, opened up a can of Orange Crush, poured it into a bottle for an infant, and when they asked what she was doing, she said, well, I'm giving my baby orange juice. They said, that's not orange juice. And they tried to finally teach her. But they also took her back to the home that she was going to be going back to. It was a trailer. It was in North Dakota. And when they went into the home, there was a rug across the living room floor. And when they picked up the rug, it was a piece of plywood. Picked that up, and it looked straight down into the ground below the trailer. Also in the home was a mother, her mother, a grandmother, and a teenager. No, it was a preteen. Had they not done these home visiting programs, that child probably would not have survived that North Dakota winter. This program teaches people how to take care of themselves. We all have had the opportunity of probably having really great parents. Another one of the examples that was given there was a mother that was there, and she stood up in front of me, the Secretary of Health in the state of Colorado, and said, I entered this program because I needed to. I needed to break the cycle of abuse that was plaguing my family. I did not want to be that type of mother to my child. Her husband was there. Her husband said, I just wanted to be a good dad to my parents or my kids. And they were young kids, 4 years old and an infant. He goes, I'm not the smartest person in the world. The McVie program taught them. They have the strength to be a good parent. And through this program, they are helping to educate their kids, helping them to read. All things that I think a lot of us in this room take for granted. But for some people, they just need to have those basic skill sets applied to them because they never had them when they were children themselves. So I'm really proud of this program. It is definitely a MAHA-driven program because it helps with nutrition, it helps with physical activities, it helps people take care of themselves. It helps identify an individual, and the government approach is you can take care of yourself, you just need a little help. And again, Secretary Kennedy supports this program. Secretary Kennedy understands that we need to have people raise their children, take care of their children, but not rely on the government, solely on the government, to take care of their children.
Thank you. Dr. Lambert, back to you. And as we are wrapping up this panel, could you share more about SAMHSA's vision as it aligns with MAHA?
Sure, thanks. First, I just want to say it's so great to hear the passion you have, and like what I'm getting listening to both of you is how much we all want the same outcomes. So there's no politics here. It's everybody wants happy moms and happy kids and all that. So it's awesome. So last week, SAMHSA came out with their new strategic priorities. The aim of that was to be more focused, more efficient, and high impact to align with MAHA and the Secretary's vision. SAMHSA plans to kind of lead the charge around changing the trajectory of serious mental illness, addiction, and loss of life. So I want to read to you the 6 priorities that came out. The first is preventing, we're back to prevention, substance abuse, misuse, and addiction. The second is addressing serious mental illness. The third is expanding crisis intervention care services. The fourth is improving access to treatment. The fifth is helping people achieve recovery and sobriety. And the sixth is identifying and addressing emerging behavioral health threats. So you can see outcomes we all want. We're going to do that by using innovative grants and programs and interventions that address root causes. So we're not putting Band-Aids on things, but that's the way MAHA works about nutrition and so forth, is really addressing the causes of chronic disease. And some of the examples of a couple of things we've done, we have recovery housing. We just gave $43 million supplemental funding to expand youth recovery housing. A $19 million supplement just went out for homeless people with a serious mental illness. That's part of the assisted outpatient treatment supplement. And then the last one that I helped work on is the hepatitis C funding opportunity. So hepatitis C is now, it's a chronic disease, of course, and it's now curable. And the fact is that you can take an 8 to 12-week course of medicine and actually be cured. So the beautiful thing about this program, because it's linked to recovery and access to care for treatment for substance use disorder. So we actually have a program that will cure a disease and also treat. So that was a wonderful thing to work on. So, you know, we're really doing our best at SAMHSA to really align. I mean, I think what SAMHSA's always been about, substance abuse and mental health, is getting people better. And so, like I said, we're outcome driven, and we want to do this in a much more efficient way than it's been done before. Thanks.
Thank you. Administrator Engels and Dr. Smith, both of you take some final thoughts on where you see HRSA and other divisions of HHS making America Healthy Again vision to life, and where you see the most synergy.
I'll start it off. I think it's interesting as we meet today. Today happens to be Patient Safety Day. And it's also part of Telehealth Awareness Week. The Health Resources and Services Administration has some very unique programs. For example, the Federal Office of Rural Health Policy is the only rural health policy program in all of HHS. We also function and actually are the leader on the telehealth services that we offer and work with providers across the country. The President has put in his budget and a significant increase for telehealth services. The backbone of what I believe to be the MAHA movement is really one of the areas that I'm most proud of at HRSA, and that's the federally qualified community health centers. Last year, they served 32 million patients across this country in medically underserved areas all across this nation. That's an increase of 1.1 million people from the year before. They served over 1 million students in school-based programs. They really understand the patients that they're dealing with. And the reason they do is because they're community-based. And as Dr. Smith has talked about a few times, they really want to focus on how patients can take care of themselves. When you consider the population that's using a federally qualified health center, it's truly amazing the statistics I'm about to give you. They saw a 7% decrease in hypertension. Their compliance rates were higher than the national average. They saw a 6% decrease in diabetes, but their compliance rates for diabetes exceeded the national average. When you take a look at the patient population that is going to an FQHC, that's what I'm saying is amazing. You're generally dealing with patients that have a lower education, low income, relatively obese, yet they are able to do this. The reason they're able to do this, they know their communities. They know how to reach into their communities and have their communities help with this process. Every FQHC, there's 1,400 of them in the country, 16,000 sites. They have to have a board of directors. 51% of their board of directors has to be made up of people that are either patients or utilize that health center in some form or another or part of that community. They reach right into the community and learn how to take care of the residents and the patients that are there. The FQHCs are the hidden gem within the Health Resources and Services Administration. But when you talk about the economic impact that they have on their areas, it's significant. And we've got statistics to show when one leaves an area, the economic impact that it has. Employers no longer have access to health care, and their employees no longer have access to health care. Residents in that area don't have that same access. We want to continue to capitalize on that. We want to continue to work with the health centers because they are driving the MAHA initiative. They are working with patients on nutrition. They are working with patients on chronic care. They are working with patients on substance abuse and behavioral health issues, helping patients with dental care. All of this together, and they do it with an integrated care model. Dr. Smith talked earlier about some of these patients will go to a health center, and they might be there to see the dentist. But the dentist might notice something, or they might have another provider notice something about that patient. That patient will not leave that facility until they have a chance to see the providers that necessarily need to be treating that patient. This integrated home care approach is working. It is now being adopted across the country, and it is becoming a model for other health providers to follow.
Dr. Smith.
Yeah, and I think, yesterday we went to Mercy Care, and, what you notice when you go to some of the FQHCs, and there's passion and there's humanism that's there. And I think the engagement that the patients feel when they go there, they're going to listen to their providers and the staff, and they're going to take their advice because they make a connection. The people that want to be at FQHCs really want to be there, and I think everybody in the private sector, you want those first touch engagements to be positive, or else you're not going to have a good customer experience. And as noted by the stats that Administrator Engels mentioned about the hypertension improvements that are better than national average, diabetes, A1C reductions better than national average. I think a lot of that has to do with that first touch, the engagement, the humanism that you feel when you go in there. Everyone's happy, smiling. Listen, I worked still work in healthcare, for over 15 years. I know how stressed out it can be, and it might not be everybody's best day. Specifically me. I mean, I'm guilty of that. I think we all are. And I think, if we all can show that same compassion and humanism and teach those preventative strategies to our patients, that's really going to move the needle in, getting our nation healthier. And it's all about what FQHCs are. I mean, that's what they're about. And, it's just been a wonderful opportunity to really see that and see how that care is delivered. And hopefully that we can train more physicians that go into the rural underserved space. Most physicians now graduate, they want to go into specialty care. I mean, they don't want to be primary care providers. We need to change that.
Thank you. We're wrapping up a little early, but I want to thank my colleagues, Administrator Engels, Dr. Smith, Dr. Lambert. It's wonderful to work with these colleagues and everybody else back at HHS. And be assured, we are all working to row in the direction to execute the President's agenda and Secretary Kennedy's agenda. And it's a privilege to do so. I want to thank Russ and the whole team at Health Connect South. I also want to offer, if you want to leave me your business card, we have a bi-weekly newsletter that comes out of the Office of IEA. It wraps up all of the work that's being done at HHS in the previous 2 weeks. I'd be happy to add you to the newsletter, and then you can opt in on your own if you want to continue. But thank you all very much.
Thank you.